Hi, my name is Ethan Freed, and I'm the Residency Program Director for the Department of Internal Medicine at Lenox Hill Hospital on New York City's Upper East Side. In our first two videos of this series, we talked about the general quality of the institution here at Lenox Hill. We also talked about how our program maintains an environment of quality, scholarly work, and diversity and equity. In this video, we're going to discuss our constellation of unique learning opportunities that's contained within our curriculum. We're going to talk about our academic protected time, which allows us to really dive deep into individual subjects. Our interns sign their pagers out to their senior residents, and thus they have an hour and a half to 2.5 hours of protected time to really delve into case-based management and a small group discussion about a particular entity. And they do this every week throughout the year. Our regionalized floors, even though it's really an organizational aspect of our service, but it provides a very key piece of your education, which is learning to work in multidisciplinary teams. We'll talk about our formative, objective-structured clinical experiences, as well as our simulation sessions and our relationship-centered communications curriculum. Our experiential quality improvement and patient safety course, now in its 4th year, has produced an enormous amount of scholarly work on the part of the house staff. Peabody Club is a unique curriculum that is our humanities curriculum and includes aspects of medical ethics, cultural competency, and the social determinants of health. Finally, there's our 6+2 ambulatory block schedule, which allows for conflict-free ambulatory training, which is separate from our inpatient training. It also allows us to do a number of interesting things, including an ambulatory academic half-day. So let's look at these one by one. The 6+2 ambulatory block schedule is somewhat unique for our program. Other programs run a +1 ambulatory block schedule. I don't particularly care for that because in a +1 environment, somebody is coming or going off of a team every week. In a 6+2 environment, everybody rotates at the same time. So it allows us to form and unform our teams on a regular basis. Now, this is what the ambulatory block schedule looks like. This excerpt allows you to see that there's 2 weeks of ambulatory work, followed by 6 weeks of something else, followed by 2 weeks of ambulatory, and that pattern continues throughout the 3 years of training. There are some interesting things that you can do with the 6+2 block schedule. Number one, it eliminates the conflicts of inpatient and ambulatory work. In programs with 1/2 day a week of ambulatory work, you're still responsible to run back to the hospital and clean up things at the end of the day. Final admissions, final procedures, etc. But in a block schedule like this, your inpatient work is concentrated in your inpatient time, and your ambulatory work is concentrated in your ambulatory time. Because you have this time, it allows us to also provide some protected time for a variety of educational experiences and didactics. So each week of the 2-week ambulatory block includes 4 sessions, that's 4 half-day sessions of primary care clinic, and 1 half-day academic protected time. The other 5 sessions of the week include a variety of specialty clinics and additional skills. So it really allows you to have a wide range of different educational experiences. You get exposure to both outpatient medicine, both primary care, and specialty work. Let's turn to the regionalized floors and why this is part of our curriculum presentation. So these are the units of our hospital, the basic areas of our hospital: the Urus wing, the Woolman wing, the Lockman wing, which is where our step-down units tend to be, and the East wing, which is where our critical care units tend to be. In some hospitals, you're on a scatterbed environment. You're all over the hospital. Your patients may be in different nursing units or different floors or even different buildings. And you spend more time in the elevator or on the stairwell than you do at your patient's bedside. In our environment, all of your patients are in a single nursing unit, and it is the single most powerful organizational principle in which to learn care for patients in a multidisciplinary way. You are part of a medical team. You know everyone's name. They know your name. You're not just landing on some floor for 5 minutes and writing an order and disappearing. You are a member of the team. It's a rare opportunity because it requires the full commitment of the organization, and Lenox Hill has long been dedicated to regionalized floors, whereas other places are not. You're training to be part of the vanguard of modern-day physicians who work in teams. Medical care is provided as a team sport, and this is how to learn it that way. This is what a regional floor team looks like. When other places talk about teams, very often what they mean is an attending, a resident, a couple of interns, maybe a couple of students, all medical personnel. When we talk about teams, we're talking about nursing and social work and case management and pharmacists and dietitians and everybody involved in the care of your patient. So it allows for us to have 2 sessions a day, 1 interdisciplinary rounds in the morning and then a team huddle in the afternoon, where you will truly learn interdisciplinary care. Everybody works at the top of their license, and you are responsible for the medical care while the social workers are responsible for what they do, etc., etc. It allows for highly effective interdisciplinary rounds, and all residents learn the value of and the skills related to working in interdisciplinary teams. We even have a second-year OSCE, which is directed to working with a social worker on IDRs, which we'll cover in a moment. So let's talk about our curriculum, which involves communication skills and other clinical skills. The Relationship-Centered Communications course is part of our curriculum. It's taught throughout our system, and it is directed to residents, to attendings, to nurses and therapists and other personnel. It is largely based on the Hofstra Med School Communications course, and it allows us to speak to patients in a patient-centered way. We don't treat diabetics here. We treat patients with diabetes. We learn how to express empathy. We learn how to use living room language when discussing medical procedures and medical complications. And we learn to use teachback in order to make sure that patients understand what they're being told. In the PGY1 year, we have a 6-station formative, objective-structured clinical experience for our interns. These are for fundamental communication skills, including breaking bad news and taking a history in a patient-centered way. In the PGY2 year, we have another 6 formative, objective-structured clinical experiences, which give residents the skill to do a bit more complicated clinical skills, like getting goals of care established in a patient with a terminal illness, or dealing with an angry patient who wants to sign out AMA. Our intern boot camp prepares interns for the skills they'll need during the year, including setting up intravenous lines, working on their documentation, and medication reconciliation. Sim sessions prepare you for leadership on a medical team, but also how to work in a team, which is attending to patients with a rapid response or with a code blue. Clinical Chloe sessions are to learn the more sensitive parts of the physical exam on an anatomically correct mannequin, and these are done during our ambulatory block sessions. Finally, we are very happy to announce our new bedside ultrasound curriculum, which uses whole body ultrasound training in order to learn a variety of skills to augment your physical exam of your patient. So, our PGY1 OSCEs, once again, taking the Hofstra history, a patient-centered history, obtaining consent for a procedure, performing a 5-fingered cardiovascular exam, so there's a physical diagnosis portion of our OSCEs, breaking bad news, and using empathy skills like reflection, legitimization, and exploration, signing out to a colleague using IPASS, which is a very effective acronym to describe the most important parts of the handoff, and even teaching a medical student to read a chest x-ray, which augments the teaching toolbox workshop that we run in July. In the PGY2 year, there's another set of objective structured clinical exercises, including dealing with an angry patient, obtaining goals of care from a dying patient, performing a screening neurologic exam, another physical diagnosis station, performing motivational interviewing for a patient that needs to give up a bad habit, giving discharge instructions using teachback, and avoiding readmission risk. And finally, participating in interdisciplinary rounds where you'll meet not a standardized patient, but a standardized social worker. Boot camp includes setting up IVs, medication reconciliation, and using the electronic health record for documentation. Sim sessions allow you how to, allow us to teach you how to respond in rapid responses in code blues. And Clinical Chloe allows you to learn to perform the more sensitive parts of the physical exam on an anatomically correct mannequin in the ambulatory clinic area. Finally, POCUS has several sections, including thoracic ultrasound, the search for DVTs, renal ultrasound, a whole body exam having to do with shock, and an exam that's related to patients with abdominal pain. Here's a photograph of intern boot camp, learning how to do phlebotomy and IVs on a simulated arm. Here's a group of residents working with our simulation mannequin. Here is a picture of one of our OSCEs in which our senior residents play the patients. Let us turn now to our Peabody Club. This is our medical humanities curriculum. It includes elements about biomedical ethics as well as cultural competency. This is an opportunity where residents get to reflect on the care they're providing to their patients and discuss it in a small group. There are some readings involved and there are some exercises, and residents really understand how to apply the biomedical ethical principles to their patient care. They also learn about cultural competency, which includes social determinants of health, intrinsic bias, and ways of communicating with patients that allow us to understand patients' mindset as it relates to their health. So now that you understand some of the unique learning opportunities, it's important to see how they fit into the annual cycle. So if we divide the year into quarters, you can see very quickly that each quarter has its own series of events. In quarter one, boot camp, making sure we have 3 interns per team in July so that the ramp up to managing a full team comes a little bit more gradually. And everybody gets an opportunity to do inpatient medicine in the month of July so that they don't wind up on the floors in October and have never had been on the floors before. Our relationship-centered communications course starts in the first quarter, and our PGY1 and PGY2 OSCEs are conducted at that time as well. I also mentioned the teaching toolbox that we conduct in July, and individual rounds with between senior faculty and interns allows us to make sure that everyone has their own fundamentals in place. In quarter two, we begin the quality improvement and patient safety curriculum. Quarter two is when we run our fellowship and job fair, as people are starting to think about applying for those things. We begin our academic protected time series, where interns sign their pagers out to their seniors and have some time to go over medical topics in a very intense and deep dive way. Quarter two is also when we start interviewing, and that requires a lot of effort on the part of the faculty and some residents who chat with our new interviewees. You'll experience that at your interview. It's when we start measuring the milestones in a formative way so that we get people to know what they're good at and what they need to be better at. And this, of course, is when the in-training exam scores are available and we start making up our didactic club for people with low in-training exam scores who need a little bit more help preparing for boards at a later time. Specialty and management rounds begin in quarter two as well. In the third quarter, cultural competency and ethics has been moved to just the beginning of the calendar year and comes in the middle of the QI and patient safety course. Third quarter is also when the winter doldrums occur, and this is when we start doing a lot of wellness activities to get people's morale up. We plan our retreats and a variety of other activities for quarter three. And in quarter four, we have our summative milestones where people find out how they did over the course of the year. Quarter four is also for Freaky Fridays, where interns and residents can switch places and start learning how to manage teams, which they'll have to do in just a month or so later. It's when we pick our resident grand rounds of the year and present that at our departmental grand rounds to all of our faculty. This is when we run our research fair and we have new chief activities as well. So it's a pretty busy year, full of unique learning opportunities, and I think that these are another reason why you should consider Lenox Hill for your training. Join me for the last video. Thank you very much.